Dear colleagues, it's a pleasure to be part of the Glosen meeting today, and I'm grateful to Manuel Praga for inviting me. It's unfortunate that we have seen so much suffering due to the COVID virus, and I hope and expect that we will see improvements in 2021 and can meet live in the near future. My presentation today will cover recent advances with respect to PLA2R antibodies in membranous nephropathy. You all know that membranous nephropathy is the most common cause of the nephrotic syndrome in the Caucasian population and accounts for approximately 30% of patients with nephrotic syndrome. The first description of membranous nephropathy stems from 1957, and it was characterized by thickened GBM in a silver stain, and by immunofluorescence and electron microscopy, there was the characteristic presence of deposits containing IgG and C3. The natural history of membranous nephropathy without treatment is clear. If you consider long-term follow-up, then approximately 50% of the patients develop partial or complete remission, and the other 50% of the patients will progress and eventually need immunosuppressive therapy. We can predict the outcome by using biomarkers. The best known risk score is the so-called Toronto risk score, which predicts remission and progression with an area under the curve of 0.78. The Toronto risk score is composed of maximum urinary protein, creatinine clearance, and the change in the creatinine clearance over a 6-month period. We have shown that measurement of urinary low molecular weight proteins, such as beta-2 microglobulin or alpha-1 microglobulin, can predict outcome with similar accuracy. It is evident that patients need treatment, and already more than 30 years ago, it was shown that alkylating agents can improve outcome and prevent the development of end-stage renal disease. The treatment consists of cyclical treatment with steroids and either chlorambucil or cyclophosphamide. Then in 2009, little more than 1 decade ago, there was a dramatic change in our knowledge about membranous nephropathy. The group of Beck and S.E.N discovered that in more than 70% of patients with membranous nephropathy, antibodies against the phospholipase A2 receptor were present in the serum. And this provided evidence that membranous nephropathy is a renal limited autoimmune disease, with the PLA2R protein being the major causative antigen. Very short thereafter, one pitfall was noted, and that was that in some patients, PLA2R antigen could be found in the kidney biopsy by immunohistochemical staining, but in some of these patients, there were no serum antibodies present. I will now discuss with you the usefulness of the measurement of PLA2R antibodies as a biomarker for the diagnosis of patients with membranous nephropathy, to predict the outcome in patients with membranous nephropathy, and to guide treatment. First, with respect to diagnosis. This is from a meta-analysis published in 2014, where the authors summarized various papers, more than 10, and showed that the specificity of PLA2R antibody testing for diagnosing membranous nephropathy was close to 1. The sensitivity is lower, but that's not unexpected, since we know that more than 20% of the patients with membranous nephropathy do not have antibodies against this phospholipase A2 receptor. An interesting study was done by the Mayo Clinic. They summarized the data of all patients tested for PLA2R antibodies. They retrieved the data of the patients who were positive in the PLA2R antibody test. These were 132 patients. Then they excluded patients with secondary membranous nephropathy and evaluated the kidney biopsy in the patients with maintained kidney function, eGFR above 60, and patients with slight or more severe renal insufficiency, eGFR less than 60 mL per minute. If we then look at the value of the kidney biopsy, it became evident that in patients with maintained kidney function, the biopsy did not provide relevant information. In contrast, in 5 out of 37 patients with renal insufficiency, there were biopsy findings which could have changed or added to the treatment decisions. And these findings were tubular interstitial nephritis, crescentic glomerulonephritis, focal segmental glomerulosclerosis, and diabetic nephropathy. Still, it's clear that to diagnose membranous nephropathy, we do not always need a kidney biopsy. The second part is on the predictive value of PLA2R antibodies. In one of our studies, which we conducted together with the group of Paul Branchley in Manchester, we could show that patients with high antibody titers had a lower likelihood to develop spontaneous remission, whereas patients with low antibody titers had a higher likelihood of developing spontaneous remission. Although the studies suggest that PLA2R antibodies might have prognostic value, we should be careful. The study was a small study, including less than 100 patients. There was no multivariable analysis done, and there is thus no proof that measurement of PLA2R antibodies is better in predicting outcome than using the Toronto risk score or measuring urinary alpha-1 microglobulin. Another interesting study, published in 2015, is the study published by the Bergamo group of Rucinenti and Professor Muzzi. And they analyzed the outcome in patients treated with rituximab. And also in this study, the patients were grouped in tertiles according to the level of the antibodies. And it's evident from this figure that patients with low antibody titers responded very well to rituximab, whereas patients with high antibody titers did not respond very well to rituximab. So this slide suggests that the antibody levels could be used to predict the treatment response. When talking about biomarkers and risk prediction, I think it's useful to read this paper, which is published by the Food and Drug Administration and which described the use of biomarkers in clinical practice. The FDA indicates that biomarkers can have various goals. So biomarkers can be used for diagnostic purposes, for monitoring purposes, etc. I would like to focus on the central issue in the red circle, the prognostic and predictive value of a biomarker. And these are not the same. A prognostic biomarker is defined as a biomarker which helps to identify the clinical course and the progression in patients who have the disease. In contrast, a predictive biomarker defines the outcome in patients with a disease who receive treatment or are exposed to an agent. Thus, a prognostic biomarker predicts the natural course of disease in untreated patients, whereas a predictive biomarker predicts the response to therapy. Since many studies published in recent years have always combined in the cohorts treated and untreated patients, it's very difficult to determine the prognostic and predictive value of PLA2R antibodies. And that's why we have evaluated in our cohort the prognostic value of PLA2R antibodies. To this end, we selected a cohort of untreated patients. These patients did not receive immunosuppressive therapy unless renal function had deteriorated or unless there was an indication because of the presence of a very severe, untreatable, life-threatening nephrotic syndrome. The endpoint for our analysis was disease progression, and disease progression again was defined by either renal function deterioration and or the need of immunosuppressive therapy. Our cohort included 156 patients positive tested for anti-PLA2R antibodies. And the minimum follow-up of this cohort was 60 months. And at the end of this period, 101 patients, almost 2/3, had progressed. 51 patients had developed a spontaneous remission, and only 4 patients had persistent proteinuria, comparable to the figure I showed you before with respect to the disease course in patients with membranous nephropathy. This is a figure showing the outcome in our patients. In red, the rate of progression, and in blue, the rate of remission. This table shows the baseline characteristics of the patients according to the tertile of antibody levels. In patients with the highest antibody levels, so patients in the 3rd tertile, were comparable with respect to age and gender. Also, kidney function did not differ. Still, there were some slight differences. Patients in the highest tertile had a lower serum albumin, a more severe proteinuria, and a slightly higher excretion of urinary alpha-1 microglobulin. In univariate analysis, it was evident that patients with high PLA2R antibody levels progressed more than patients with low antibody levels. However, if we then performed a Cox regression analysis, it was evident that the added value of PLA2R antibody levels was negligible. Model 1 included serum creatinine and UPCR. This model predicted outcome progression with an area under the curve of 0.73. This is not unexpected, since renal function and proteinuria are the best known and validated biomarkers. In model 2, we included the log-transformed antibody levels to the model. And as you can see, the model did not improve. And this is also shown by the fact that the hazard ratio was not significant. So PLA2R antibody levels did not provide added value to a model including creatinine and UPCR. In contrast, alpha-1 microglobulin measured in urine provided added value, since model 3, which included serum creatinine, UPCR, and alpha-1 microglobulin, had an area under the curve of 0.84, so an improvement of 0.12. And you can see in this column, looking at the hazard ratio, it's clearly significant for alpha-1 microglobulin. We further illustrated this by looking at the individual antibody levels in patients who either had remission and progression. And here again, you can see that there is a slight difference. So patients who progressed had on average higher antibody levels, but you can really see easily that there is a large overlap, indicating that for the individual patients, it's very difficult to use the antibody titer to give a realistic view of the prognosis without treatment. We try to validate these findings by looking at the GEMRI-TUX study. The GEMRI-TUX study is a randomized controlled trial conducted by Pierre Roncault and his investigators in France. And this study compared rituximab versus conservative treatment. We evaluated the patients who were in the control group. So these patients did not receive rituximab. And there were 21 patients with data available. In 13, during follow-up, there was no remission. in 8 of these patients during follow-up, there was a partial remission, and these patients did not need additional treatment. And although there was a higher value of PLA2R antibodies in the patients who did not develop remission, there was no significant difference, as you can see by the large range. So again, this confirms that the PLA2R antibody levels, although significantly different, do not allow to predict the outcome accurately in an individual patient. Still, this figure is of value. This again shows that there is a value of PLA2R in predicting the outcome in treated patients. So PLA2R antibodies do not have prognostic value, but they have predictive value. This has been confirmed in the recently published Mentor trial. In this study, patients received either rituximab or cyclosporine. And as you can see here, the response, in this case, the immunological response, but this was also true for the clinical response, the response to rituximab is dependent on antibody level. The remission rate was high in patients in the lowest tertile of anti-PLA2R antibodies, 82.4%. The remission rate was clearly lower in patients with high antibody levels at 43.8%. Thus, again, this study confirms the predictive value of PLA2R antibodies in predicting the outcome in response to treatment with rituximab. Thus, this is another indication on the predictive value. If you measure antibodies at the end of immunosuppressive therapy with either cyclophosphamide or mycophenolate mofetil, the disappearance of antibodies has some predictive value. If the patients remain PLA2R antibody positive, then they do not remain in remission. In contrast, the likelihood of remaining in remission if the antibodies disappear is much higher. The role of PLA2R antibodies in predicting outcome in response to treatment has not been studied in detail. However, there is some indication that it might not be true for all treatments. And this is a slide showing a comparison of data obtained in a center, in our center, where all patients were treated with cyclophosphamide, and we compared the data with patients treated in Italy with rituximab. And although there was no difference in complete remission rate, it's the evidence that the partial remission rate obtained with cyclophosphamide was higher than the partial remission rate in rituximab-treated patients. And after that, we compared outcome in patients treated with cyclophosphamide and compared it to patients treated with rituximab. And this is from the Paris cohort and from the Gemritux study. And what we did is actually we looked at the response of PLA2R antibodies. And to this end, patients were again classified according to antibody levels. And then we evaluated if the antibodies had disappeared 6 months after start of treatment. And all these patients had antibodies at the start of treatment. That was the selection criteria. And then after 6 months, we identified the patients with disappearance of antibodies. And this percentage is given in the blue bars. And as you can see, cyclophosphamide resulted in disappearance of antibodies in more than 80 to 90% of patients, and there was no clear effect of the antibody level. Clearly different is the response to rituximab. Rituximab induced disappearance of antibodies in approximately 70 to 80% of patients with very low antibody titers, but was unable to induce disappearance of antibodies in patients with very high antibody levels. And you can see here is a gradual response suggesting that the antibody levels predict the response to rituximab in inducing immunological remission. And this is clearly not happening when we use cyclophosphamide. So I come to my conclusions. I can say that the measurement of PLA2R antibody can be used, and antibody positivity is a good biomarker of a diagnosis of membranous nephropathy. And you must remind that the immunofluorescence test in this respect is more sensitive than the ELISA test. So if you want to diagnose membranous nephropathy, the IFT probably is the best test. We now know that high levels of antibodies are associated with a more increased risk of developing disease progression. However, ELISA titers are not a very good prognostic biomarker. And if you look at creatinine and proteinuria, there is no added value. In contrast, PLA2R antibodies might be useful for guiding treatment, which means that measurement of PLA2R antibodies might predict a response to some treatments and might enable you to consider the type and duration of therapy. However, as I showed you, the evidence is still limited and we need studies to confirm this. But this could help in the future to select the best treatment for the individual patients. There are many unanswered questions. One is the difference between titers at presentation at the time of relapse. We have the impression that the titers at the time of relapse are lower, and even when we adjust for the severity of the nephrotic syndrome. And secondly, we are always trying to see if treatment results in immunological remission. And we certainly have the impression that the cutoff value of 14 relative units per ml to diagnose membranous nephropathy cannot be used to define complete immunological remission. And I suggest that in the future, probably we will need to use a cutoff value of 2 relative units per ml. So I thank you for your attention, and I am open for questions. Thank you very much.
Thank you very much, Jack, for this fantastic review. Very, very intelligent, very balanced, and I think that presentation very important for clinical practice. So I'm going to see the question. Yeah, the question is, we know that immunological response usually happens before clinical response, but sometimes some patients maintain PLA2R antibody positive when they are in clinical response. Do you have an explanation for that?
Well, obviously that's a very good and difficult question, but we have the same experience that there are some patients with proteinuria remission who have persistent antibodies, and I think it suggests that our knowledge about these antibodies is not sufficient. I would like to speculate that maybe measurement of subclass of IgG could be very important, but because I think that there is some suggestions that the IgG1 subclass of antibodies may be the pathogenic one, and maybe the patients who have persistent antibodies in the light of persistent or in the light of remission, maybe these are the ones who have some IgG4 remaining antibodies, which might be less pathogenic.
Yeah.
The discussion is maybe there could be a difference in the specificity of the epitopes, although the data on epitope and epitope spreading, in my view, is not very evidence-based.
Yeah. Yeah, I have some questions for your fantastic presentation, Jack. One of them is, what is your opinion about, you know, that there is recent studies, particularly from Gerard Lambeau, have shown the value of intrapodocytic antigens that could amplify the effect of antibodies against anti-PLA2R. I mean, it's possible that we are looking only for anti-PLA2R antibodies and there are other antigens in the podocyte. that we are not measuring and could explain perhaps some of these discrepancies that we are found in clinical practice?
Yes, I think that, we are measuring just one antibody with a simple technique like the ELISA technique. And then obviously there are differences in the antibody characteristics. There could be differences in the expression of the antigen and also the type of the antigen, at least the molecular structure of the antigen. And then obviously what is also, I think, at the moment unknown is if the damaging effects of the antibodies are really only dependent on complement, or that maybe in the podocyte it could be dependent not on complement activation, but just on, for instance, activation or stimulation of the C3A receptor. So, and then patients might be very different in expressing the receptor, in the signaling process of the receptor. So I think we now know to measure the antibodies, but we need to gain a lot more knowledge about the precise effects of the antibodies on the podocyte.
Yeah. Well, another question. Yeah. A question from Anna Jarque. How are those PLA2R positive patients interpreted in secondary causes? I think that, yeah, this was a question I was going to make to you, that perhaps it's the same question. The finding of PLA2R positive in a membranous nephropathy is absolutely equivalent to primary. For instance, a frequent question is a patient with membranous nephropathy positive for anti-PLA2R antibodies, and the patient has a cancer, for instance, no? What is the interpretation? No?
Well, the interpretation is obviously very difficult, because in the literature, most patients who have membranous nephropathy and antibodies and at the same time are diagnosed with cancer, they are considered secondary membranous nephropathy. But I'm not sure. I think that in many patients, this is a coincidence. And obviously, if you have a male patient of over 60 years old who has primary membranous nephropathy, with positive PLA2R antibodies, if you are going to try to find for prostate cancer, the risk of finding prostate cancer in a male of 60-year-olds is not low. So I would say it's just it's by accident that you have this combination. And most patients in the literature where they will have PLA2R associated membranous nephropathy and cancer, then if you look at the data, then in most of these cases, there is a really large delay between the diagnosis of membranous nephropathy and the diagnosis of the cancer. Sometimes it's 12 months before, sometimes it's 12 months after. And I think really, if you have PLA2R antibodies, it's most likely to be primary. There is one situation which I do not really understand, and that's a situation that some authors have described, that they have this association between sarcoidosis and membranous with PLA2R. Also there, I think it's sometimes difficult because sarcoidosis is a disease which is seen also not infrequent. So also that might be just a chance association.
Yeah, okay. Two final questions of clinical importance. One of them is one patient, for instance, who achieved a partial remission, proteinuria 3 grams per day, for instance, but anti-PLA2R antibodies remain in a stable titer about, I don't know, 100, for instance. What is your recommendation? Wait and see, add rituximab, for example?
Mm-hmm. Well, I think in practice, I think it's very important to try to get rid of the antibodies. But in my practice, I like to look at clinical data, which means that if the patient has a low amount of proteinuria and his serum albumin has increased, even if there are persistent antibodies, I would wait because, you know, what we discussed before, there are even some patients with almost complete remission who have persistent antibodies. So I don't think it's good as a clinician to just look at laboratory data and treat the patient just based on an ELISA test. Obviously, if the patient has a partial remission with proteinuria going down to 3 grams, but his albumin is still low, that would be a different situation. And there I would try to add another treatment to try to reduce the antibodies. But I think we should first look at the clinical features of the patient and not just treat based on antibody status alone.
Thank you. Another interesting question on the Mark Castilla. A patient treated with a modified Ponticelli regimen that makes anti-PLA2R negative. Could the treatment be stopped before the 6 months are complete?
Yes, okay, this is a very good question. And maybe next year I can give you the answer, because at the moment we have treated 72 patients with membranous nephropathy, and the patients were treated with cyclophosphamide and steroids, but we didn't use the cyclical regimen. We used daily cyclophosphamide, like we have done before. And then we measure antibodies after 8, 16, and 24 weeks. And when the antibodies are negative in the immunofluorescence test, we stop the treatment. And I can tell you, yesterday we looked at some initial data. I can tell you that almost 70% of the patient have lost antibodies after 8 weeks. So we have stopped treatment after 8 weeks in these patients. We are now analyzing the long-term follow-up to see what is the relapse rate in these patients and what is the real remission rate. Well, I'm sure we will have the data within 3 to 4 months. So my personal impression is that the treatment is very well tolerated. I think we will see a little bit higher relapse rate than with our long treatment protocol. But in terms of side effects, the patient tolerate this 8-week course very well. And I have one patient, which I yesterday have seen. She started in 2014 with this treatment. She has had 2 relapses since then. So she received 3 times 8 weeks treatment in this 5-year period, but she never had any side effects. So in the end, that maybe even in this patient, I think it was better than giving 6 months on a row. We have, I think, for now, after a follow-up of 40 months, I think at least 50% of the patients did not have a relapse. So I think it's a reasonable protocol, but we have to compare. But I think it looks very well.
Okay, thank you. Another question is about the role of plasmapheresis in patients refractory to rituximab, cyclophosphamide. Do you have any experience?
Yeah, I have no experience. I think it is a logical treatment if you consider that the antibodies are pathogenic. I think if you really have antibodies present and you do not respond to cyclophosphamide or rituximab, then in the future we might need to consider other treatments like daratumumab or other anti-CD38 drugs. What my personal experience is that if you use cyclophosphamide, there are not many patients who are really immunological resistant. Only a few. And the first step would be, if you have antibodies after rituximab, I would add after cyclophosphamide, I would add rituximab, and then if it's not working, personally, I think we should go for plasma cell therapy. Okay. Because the plasmapheresis is only a temporary measure. You will not have a maintained response after that.
Okay. Another question from Leonela Luzardo from Uruguay, an example of the expansion of the Glosen group. The question is, a patient with a stable clinical remission for years, how often would you measure PLA2R? And what would you do if you find them newly elevated in the absence of clinical relapse?
Yeah, I know this is heavily debated. I know that in Hamburg they suggest that you should treat. My personal feeling is that if your patient is in good remission after treatment, I just continue measuring proteinuria, and only if the proteinuria comes back, I measure the antibodies to see if the disease is coming back. I think that if patients are in remission, I never would treat just based on the antibodies alone, because we don't know if they are really pathogenic at that stage. And I don't like to treat patients with immunosuppressive therapy if they have no clinical evidence of disease. But I know that it's not done in every center, but I think we should treat disease and we should not treat ELISA values.
Okay. And another question from Jorge Rojas. Why do some patients with nephrotic syndrome have low serum anti-PLA2R values at the onset of the disease? Is it possible that they have a massive deposit of antigen antibody complex with PLA2Rs in the podocytes, or that they are expressing other autoantibodies such as antithrombospondin and others?
Yeah, so the question is why some patients with low titers have severe disease? Is that?
Yeah, a patient with nephrotic syndrome with a low serum anti-PLA2R antibodies.
Yeah. So I think there are two answers to that. One is that I think in the beginning of the disease, you have most antibodies are bound in the kidney, and you will not see the antibodies in the serum. So it takes time. So in the beginning of the disease, you have nephrotic syndrome, low antibodies, and then it takes maybe weeks to months to see the increase. The second thing is that there could be, let's say, podocyte sensitivity. You know that in Afro-Americans, you have this ApoL gene polymorphism. And I think also in our populations, there will be podocyte genes which make you more likely to get damage to the podocytes. And the third issue, and that's interesting, I think, from some observations, we have the impression that patients with a relapse, they have more severe disease, even when they have very low antibody titers. And maybe patients with a relapse have already damaged podocytes or have already immune complexes in the kidney, and they need only few additional antibodies to get all antigens responding or occupied. So I think in patients with a relapse, we often see very low titers. Actually, we are now looking at this antibody-guided treatment. What we see is that some patients, they have severe clinical relapse, and the antibody titers with ELISA are between 2 and 14. So very low. So maybe the relapsing patients are different than the patient with first presentation.
Okay, thank you. And the final question is, are you following the recommendations of Fernando Fervenza about don't perform renal biopsy in a nephrotic syndrome with normal renal function and tested positive for anti-PLA2R antibodies in your practice?
So we currently measure the antibodies. If they are positive, we consider that it's membranous nephropathy. Then we measure the risk profile, and if they are low, moderate risk, we do just conservative treatment and just wait for spontaneous remission to occur. If the patient is progressive and needs cyclophosphamide, we are still performing biopsies. But I would say we are still performing biopsies, but if the patient has a very high risk of bleeding or has only one single kidney, I would still start treatment without the biopsy, because I think if you have PLA2R, you will always find membranous nephropathy.
Okay, thank you very much, Jack. This has been a fantastic talk and very interesting answers to questions. So I will see you tomorrow. And Gemma, ¿cierras tú la sesión? ¿O cierro yo?
Cierra la Manolo.
Bueno, pues muchas gracias a todos. Creo que ha sido una experiencia nueva para mí particularmente, que ya no estoy en edad digital, al principio un poco difícil, pero después me he adaptado muy bien. Y bueno, yo creo que ha estado muy bien, unos casos clínicos interesantísimos, muy buenas discusiones y al final la excelente presentación de Jack Wessels. Por tanto, seguimos mañana. Muchas gracias y mañana continuamos. Adiós. Bye bye, Jack.